is Dr. Ramesh Bhat. Sir, may I request you to come on to the dais? Dr. Ramesh Bhat is a professor and head of the Department of Shalya Tantra of Sri Sri College of Ayurveda Science and Research, Kanakpura Road, Bangalore. Specialized in surgery and Ayurveda management for anorectal diseases like anal fistula, anal fissure, piles, etc. Expert in Ayurveda surgery, especially Ksharasutra therapy in the management of anorectal diseases. He will be presenting a case on a unique fistula case. Sir?
Good evening, everybody. My sincere thanks to the organizers for giving me an opportunity to share a unique case which I have treated in our hospital few years ago. And this is about anal fistula, and this case is, as for the literature available, it is a case which is reported first time in the world, including in the modern surgery, and no surgeon has come across such a patient where an anal fistula which is extending to the left foot. Therefore, as you know that the earliest reference is available in the surgical textbook about Bagandhara. Recently we have seen some of the discussions about surgical procedures, which is Indian literature, which is given by Sushruta recently. This was word Bagandhara is also mentioned by him, especially which is now correlated to anal fistula. Therefore, different varieties of fistula have been mentioned, the complicated tract, curved tract, in the different Bheda, they said as Ushtragriva, Shataponaka. Therefore, such fistulae were common in surgical practice. And sometimes it is difficult to diagnose anal fistula when the patient presents with the unusual signs and symptoms of the disease. Therefore, the cases which I treat in many instances is misdiagnosed by the earlier surgeons. As the fistula is the one disease where the patient may come in a very rarest or unusual presentations or signs and symptoms. This is one such case where the patient has come with the very rarest and unusual form of signs and symptoms. Therefore, Ksharasutra therapy is being practiced in India in high success rate. About the recurrence rate is hardly 3%, whereas in case of, next slide please, whereas in case of surgery it is more than 53%. I am going to take hardly 10 minutes about one single case which I have treated. 48 years old male patient, petty shopkeeper by occupation, came with a repeated abscess, boils on the left limb, lower limb, from the thigh to the foot. And this is associated every time in every such episode. He used to have fever with chills. And patient every time in earlier episodes, he has met surgeon, general surgeon, and they never thought of this anal fistula. Therefore, they have drained it every time they admitted IV antibiotic, IV fluid administration under spinal anesthesia. And this is between 2005 to 2008, this was happened. Next. You can see that this is the patient, there are incision marks, scar where he used to get different boils from the thigh region to even up to the foot and in different places. And he used to undergo incision and drainage. The patient was a case of periampullary carcinoma. He underwent Whipple surgery by about 20 years ago. Therefore, the patient was immunocompromised and general condition was very poor. Even he has been to ICU care after this kind of attacks. Next. Therefore, at the fifth episode, he visited our hospital. On examination, there was a sinus in the left mid thigh. Therefore, when he came to us, he had a thigh sinus where there is some serous or pus discharge was found. And there was no opening or any classical signs and symptoms at the perianus region or in the gluteal or ischiorectal area. Therefore, the multiple scars on the left foot, which he was giving the history that he had used to have such boils or abscesses. Digital examination also done, but it was normal except the first degree of internal hemorrhoids. And probing was done through the opening in the thigh region. Therefore, that was the only one indication that the sinus he had when he came to us. We have done the probing, and the probing was going towards the popliteal fossa and towards the gluteum, not deeper or close to the anus. Next. Therefore, suspecting the anal fistula with the rectal communication, we have advised for MR fistulogram, MRI study, and the MRI showed that there is a anal fistula, so rather it is diagnosed as rectal fistula. At 5 o'clock, it has got an internal opening. Therefore, from the gluteum, under the deep gluteus, that is under the gluteus maximus muscle, there was collection from the gluteus maximus, from the left gluteus region. It is pouring towards the thigh, and from the thigh towards the knee, knee to the leg, leg to the foot. This was the course which we, and patent track we could see about 21 centimeter from the left gluteal region. Next. Therefore, this is the fistulogram which we have done, that's called MR fistulogram. We could see from the back it is going like a tunnel and towards the lower limb, towards the knee. Next. Therefore, what we have done, see, as an initial part of the treatment from the thigh, what I have done is I just pass a thread in the thigh region only. Wherever it goes towards the gluteum, we pass the thread about 4 to 5 centimeter. And Ksharasutra is placed, and 4 to 5 times we have changed the Ksharasutra in the thigh region. Therefore, once we started changing the Ksharasutra, the person has developed an abscess in the left gluteum. And the Ksharasutra which we use is Gugulu-based Apamarga Ksharasutra, where Gugulu, Apamarga and Haridra is being used, total 21 coatings. And UV radiation is passed and packed. Such kind of Gugulu-based Ksharasutra we used in this particular case. Next. You can see the patient in lithotomy position now. Left thigh region he had a sinus, and we have made another artificial opening, and we passed the thread. Around 4 times we have changed the thread in the thigh region. After a month of changing the thread, that is from the day of primary threading of the thigh region, he developed a huge abscess in the left gluteum. Next. Therefore, 4th week, the changing the thread, he developed an abscess. Then what we have done is, under anesthesia, we have drained it in the deep part of the gluteus maximus, and we pass the probe, and from the left gluteus maximus, or where there is a collection, we pass the probe and we have done the primary threading, keeping the surgical wound open for further dressing. Next. You can see that this is what we opened, and we passed the probe from the gluteus region towards the rectum. Next. Therefore, primary threading is done using Ksharasutra, and the standard technique of method of changing Ksharasutra and primary threading, everything is followed as per the standard protocol of Banaras Hindu University, Varanasi. And after 4 weeks of Ksharasutra treatment, the thread from the thigh was removed, and 8 weeks it showed once we started the changing of the thread from the gluteum to the rectum, that is the primary fistula, the thigh region which I have placed earlier, the Ksharasutra is removed. And it is a very simple reason that the highest dependent area, or rather collection area, is left gluteum. If it is drained by an adequate incision and curettage, after that curettage is done, there is no chances of further flowing towards the thigh or the limb region. With that principle, the thigh Ksharasutra is removed, and we are just started changing the thread from the gluteum to the rectum directly. And after 8 weeks, the complete closure of the thigh opening it was dry, and even rest of the small boils which we could see in the left lower limb, everything is closed, rather it is fibrosed. Next. Then this is what you can see. We have done a primary threading from the surgical wound towards the rectum at 5 o'clock position. As you know that the incision, the place of incision, your patient is in lithotomy position. The incision, the wound, you can make out from that deep plane, it is going towards the thigh and the lower limb. Therefore, as we have made a wide surgical wound, the drainages or the rather drainage started happening at 5 o'clock position. The rest of the tract is closed towards the limb. Next. Now the Ksharasutra changing is continued like any other rectal fistula. About 32 times we have changed the thread, and after completion of the 32 times of Ksharasutra changing, patient is totally all right. Now it is next piece. You can see this is about 6 years. After 6 years of the treatment, there was only a scar, but there was no discharge, or there was no such episodes of abscess or so any foci of infection in the left lower limb. Next. Therefore, a presentation of anal fistula in the clinical practice is a challenge. For your information, recently I have treated one more patient where patient is diabetic. He has come with the repeated abscess in the just inferior to the umbilicus. And he had underwent the excision for diabetic carbuncle about 3 to 4 times. And recently we came to know that the anal fistula at the 6 o'clock position, it is opening to the anus, going to the left gluteum and to the left groin, and under the pubic symphysis, it is communicating to the infraumbilical area. Therefore, these are all the challenging presentations for the point of diagnosis. Here in this case, though the tract was noticed till the level of left thigh, there was indication of collection till the foot, earlier episodes of abscess. Therefore, for such collection or abscess, incision and drainage was done several times, and such scars at the different levels were noticed in the limb. Next. As for the standard treatment of anal fistula, complete tract should be laid open or excised. As per reference of Sushu Samhita, ancient Indian surgical text, Ksharasutra treatment was mentioned. Next. Therefore, it is an ideal management to the patient, old age patients having respiratory cardiovascular disorders, to avoid the surgery and to prevent the recurrence. No such systemic side effects encountered in any of the Ksharasutra therapy. Post-operative tissue damage is very minimal. Anal function, anal continence is maintained. Anal sphincter tonicity is also maintained. Patient is ambulatory throughout the course of treatment. Next. Therefore, Ksharasutra therapy and anal, it is the earlier study which is done. Anal incontinence is nil, and high it is in conventional surgery. Rate of recurrence, it's, as I said, 3.3, whereas it is 26, and it is much up to 53% in case of high-level fistula. Next. Therefore, in this case, small tract at the level of thigh, about 2 centimeter, in the Ksharasutra was played only for 4 weeks, so that the rest of the tract is closed. And neither lay open, excision or anything is done for the whole tract or the whole length of the tract. The thread from the sinus present in the thigh was also removed after 8 weeks, and Ksharasutra therapy was adopted for a tract communicating the gluteum to the rectum like any other Bagandhara. Next. Therefore, rectal fistula, which has long communication to the left foot, presentation is a very rare case, and as for the literature available till now, is the first case is reported in the world that the anal fistula communicating to the anus, to the left foot, and this leads to a lot of confusion in the diagnosis. Therefore, this rare case is managed with the Ksharasutra with a very minimal invasive. The person was a wholesaler he was doing the sari business in Chickpet, and he has taken rest for 2 to 3 weeks during the drainage time. Otherwise, completely all 8 months he used to do his normal work. Therefore, it can be done in a small minor operation theatre setup without much cost. Next. Therefore, these are all the references earlier studies. Next. And the same case is published in International Journal of Surgery in April 2013 as a rare case of anal fistula, that is anal fistula with a foot extension treated by Ksharasutra treatment. And this surgical journal you can also see through the Google. And on this basis, they asked me to present the same case in International Conference on Surgery at Las Vegas, USA. in the 2013 September. And among the 48 papers on surgery and anesthesia related international 48 papers, around 50 countries, surgeons and anesthetists participated. And it was the only one Ayurveda paper on, like Ayurveda surgery paper which was presented. And I feel very happy and proud that Indian system of surgical technique is present in the international platform. Next please. Therefore, my sincere thanks to all my gurus, and my thanks to the organizers, Professor B.G. Gopinath and Dr. Muralidhar and team. And also I am surprised, and I should congratulate them. Having very minimum volunteers, they have done a wonderful conference. I was just sharing with Dr. Muralidhar now. It is a great thing, and it requires a lot of effort to organize an international level of conference. Having a very minimum volunteers, they have done a very good job. My sincere thanks to everyone. Thank you.